Hello, my name is Brandon Elia. Today we will be going over some current concepts in rehab for UCL Reconstruction. So some of the anatomy here, the ulnar collateral ligament is in the humeral ulnar joint. It has three different bundles of ligaments here, the anterior bundle, posterior bundle, and transverse bundle. It's also the origin site of the wrist flexor mass of the flexor carpi ulnaris, flexor carpi radialis, pronator teres, and palmaris longus. The function of the UCL is to resist valgus loading at the humeral ulnar joint, specifically during the late cocking phase into the acceleration phase. That's where most of the valgus loading is seen during the throwing motion. Late trunk rotation, reduced shoulder external rotation, and increased elbow flexion in your throwing mechanics will increase the amount of valgus load put onto the elbow. So here's just a quick look at some arm slot angles in baseball pitchers. If you can see, the first picture is kind of overhead. It's kind of more straight up and down. The second picture is what they call a three-quarter angle, which is kind of in between overhead and sidearm. The third picture is what you would call submarine throwing, which is really low to the ground. And the last picture is sidearm. The last two are the ones that are more at risk for elbow injury because there's much more of a valgus load to the elbow with that type of throwing mechanics. Some of the main causes of injury to the UCL is improper throwing mechanics. That is leading to repeated microtrauma from continuously throwing. It could also happen in acute onset of excessive valgus loading. But if you look at the bottom chart here, it's just a breakdown of some injuries seen across baseball. And Tommy John surgery is not the highest, but the most people who make up this population who get Tommy John surgery are starting pitchers and relieving pitchers, as you can see in the green and purple respectively. And here's a quick video on just what it looks like when someone does throw their arm out mid-game or on the mound, just to give you kind of an idea if you've never seen it before. So we're not watching this whole video here. I'm just going to skip through a little bit. But here's, skipped a little too far there. As you can tell, he's in an immense amount of pain after throwing that pitch there. And then we'll go to the next one here. Similar situation. He throws the pitch. This one misses off target a lot. And you can tell he grabs right for that elbow and feels a lot of pain. Most of the time, the patient will report hearing an audible pop in their elbow, along with being in a lot of pain like this gentleman here. Now we're just going to skip around a little bit to some of the other ones on this video here. Alright, here's the next one. Same thing, this guy misses as well, and he immediately is in a lot of pain. You can tell he's bracing that arm into his side there, and he runs right to the bench. So just a little bit of video to kind of show you what it looks like in the event that it does happen to you live. So just as something you're aware of. Although primarily baseball players or baseball pitchers are the ones who are seen for UCL injuries the most, valgus loading to the elbow can be seen in other sports like golf, tennis serving, overhead volleyball serving, doing a slap shot in hockey, throwing a javelin, and throwing a football. So after injury, you would see that someone would have some point tenderness over the medial epicondyle. They most likely will be unable to continue throwing or continue play. They'll have a positive valgus stress test, a positive milking maneuver, and also a positive moving valgus stress test, which will be shown in the next slide. And this person probably would be known for, or not known for, but you would just notice that they probably didn't have the best mechanics and kind of what brought them into this situation in the first place. This graphic here is just a self-milking maneuver. It's going to be a little different from the next video, but it's just something that they could perform on themselves. And while you palpate the medial joint line, you can see that the valgus stress is applied, and they're going to have a lot of point tenderness and apprehension in that position. Here are some special tests for UCL injury diagnosis and evaluation. First, we'll be showing you how to do a valgus stress test, which is palpate the medial joint line, support the forearm, and you'll be applying a valgus load to the elbow. Positive test would be pain or apprehension by the patient. Next, we will be doing a moving valgus stress test where you abduct the arm, the shoulder to 90 degrees, flex and extend the elbow while applying a valgus force with the arm, and that will, same thing as the other one, would be pain and apprehension. Lastly would be a milking maneuver. You have the patient support their own arm and flex their shoulder to 90 degrees, and you would be pulling their hand into flexion and elbow into flexion while applying a little bit of a valgus load to that arm as well. And similar to the other ones, it'd be very painful and they'd be apprehensive about it, and that would be a positive test. So immediate treatment: rest, ice, compression, elevation. You want to refer to get diagnostic imaging, primarily MRI, or you could even use ultrasound, or a combination of both has been shown to be a little bit more accurate. And then you want to prepare for pre-surgical rehabilitation plan. You got to get them kind of working towards prehab, if you will, to kind of get them ready for surgery to have their best outcomes. As mentioned, you do have to do some pre-surgery rehabilitation. First and foremost, pain control. Then you want to work on range of motion, strengthening exercises, total body conditioning. You obviously do not want them throwing anymore, because that's kind of what got them into this situation in the first place. So you want to stop throwing for the time being, and you can use NSAIDs as needed. So your patient is going to be undergoing Tommy John surgery. Why do they call it Tommy John? Because back in 1974, Dr. Frank Jobe performed the first surgery of this type on a major league pitcher named Tommy John, and he's actually in that picture in the top right there. There's currently 3 techniques that are most popular today. The Jobe technique, which is originally from the 70s, which is, as you can see here, a figure 8 type formation. They put these graft tunnels in and they loop the new graft in there and they suture it together in a figure 8 fashion. Then the docking and modified docking, which kind of use one hole in the humerus and they kind of put the 2 ends in there of the new graft and they suture it together that way. Just some patient-reported outcomes you might want to use while treating someone from this injury. You can use a disability of the arm, shoulder, and hand score, or known as a DASH, or the quick DASH, which is a little shorter and abbreviated. You may also want to incorporate a fear avoidance belief questionnaire to see how ready they are following rehab and when they get back coming from the surgery, because it's going to happen during a traumatic event. Lastly, you can also use a Kerlan-Jobe Orthopedic Clinic shoulder and elbow score, which is also known as a KJOC. So just some options for you to use. Completely up to you and what you and your staff and clinic want to use, but these are just some options. So for the next part of the presentation, we're going to do some breakout sessions. And in these breakout sessions, we're going to be doing some of the exercises that are commonly seen in UCL rehab. So if you can have access to a CLX band, balance pad, rehab putty, a body blade, a Swiss ball, and dumbbells. And if you just so happen to have a TRX suspension system laying around, you can use that too. We're going to show some advanced stuff on that later on. For the first phase of post-surgical rehab, weeks 1 to 4, our objectives here are going to be to protect the healing tissue and the graft site. The graft is most likely going to be from the palmaris longus tendon. Then you also want to reduce pain and inflammation, so ice and pain control are going to be huge. And we're going to try to slow down muscle atrophy as best as we possibly can. In doing so, we're going to do putty squeezes. We're going to work on wrist range of motion, really make sure those flexors aren't getting contracted. We can even start some isometrics of the shoulder here, avoiding shoulder external rotation. You also want to do some light cardio, put them on a bike so they can at least get some fitness out of it and they don't make any big losses there. And then, we're going to work on getting range of motion back, and to do so we're going to try to achieve 5 degrees of extension and 10 degrees of flexion per week. As long as we keep that, they should be able to get their range of motion back in a reasonable amount of time. So for our first breakout, we're not going to do any upper extremity stuff or putty squeezes as it says on the slide here. We're just going to do some lower extremity stuff that you can introduce to your patient to kind of keep them training while they really can't use their arm in the beginning, although you are working on it a lot. First one would be just some side-lying towel slides on the wall. This will really get their glutes firing really well. This will help address any lower extremity issues they may have, prior to injury. Next, we can also do some banded monster walks or lateral walking. You can do this with 2 bands, one around the knees and one around the feet, or one around just the feet and one around just the knees, depending on what you're really doing here. Next, you can also advise your patient to invest in some meridian balls, which I'll show you a quick video on those. If you've probably seen them before, but here's just another tool and something to keep them busy and to keep their hand moving while they're in a splint and kind of immobilize in the beginning stages here. So as you see here, it's just something to kind of keep your hand moving, to work on hand coordination. Start by just spinning them around in your hand very loosely, and then as you watch this video, he progresses and even adds that third ball in towards the end there. So just something to challenge your patient and keep them motivated to do something with their arm as it's kind of in that sling and splint for that first couple weeks. As you see here, it's kind of got them moving pretty good. Got a little rhythm going as well. And then you can go one way, and then obviously reverse, go the other way, work the muscles in a little different fashion. And then you see in this video they'll pick up the third one to make it real interesting. And then go one way, and then you can reverse it, go the opposite way, but just something to kind of get them moving. And it's kind of like a fun way to kind of take your mind off doing traditional rehab, and it'll kind of help them move their hand around a little bit while they're in the rehab process. Another great area to start working on is some postural things, specifically cervical spine and this shoulder posture. First thing, a lot of people do have that forward head position and rounded shoulders. So to fix that, we can kind of do a combo deal here of scapular retraction and chin tucks at the same time. Real simple. Tie your CLX band around a wall anchor if you have it, or something safe so it doesn't snap back and hit you in the face, and just retract the shoulders and do a chin tuck with it as well. And then obviously if there's any other postural things you do notice about your patient, you could take this time to kind of address those, as long as it doesn't add any increased stress to the elbow as it's kind of in the beginning phases of healing. So for our second phase of rehab here, it's typically around the 1 to 2 month marker after surgery. Our objective is going to be to make sure that the healing of that repair tissue is going according to plan. We want to gradually advance to full range of motion. We really want to get those last terminal degrees of range of motion and try to get that achieved by the end of this phase as best as we possibly can. And we can start to regain and improve muscle strength. So we're going to start some scapular and shoulder stabilization exercises. We can start light resistive wrist and forearm exercises here. Continue to work on the lower extremity and core. And again, really work on that range of motion and hopefully get the terminal end range of motion by the end of this phase. So for our second breakout here, we're going to do some I's, T's, and Y's with no weight. Very basic starter area for this exercise, and we're going to progress it as we go along with the rehab here. So you're going to see here there's going to be a good retraction and going up to a T. You're going to come down again, retract. You want to make sure you cue your patient really well to get that good retraction of the scapula there. And then also lastly an I. Just you want to progress to sets and reps of this, but those are just examples of one of each of those exercises. And as you go along in the rehab process, you're going to advance this exercise and make it much more challenging when they are getting closer to return to play. So, as mentioned, we can start some wrist strengthening here. So, we're going to start with some basic dumbbell wrist curls, wrist flex. Really want to work on that wrist flexion there. We can also do some wrist extension exercises. Then next we can also do pronation and supination with a dumbbell. You want to really start strengthening up that wrist again to kind of help regain full strength here. Then lastly, some wrist extension exercises here as well, all of which are going to help strengthen up that forearm. So for the third phase of surgical rehabilitation here, we're going to want to make sure that we're really work on getting that full range of motion and continue to strengthen. We're also going to want to increase strength, power, endurance, and we want to maintain that full range of motion that we achieved. And we can initiate some sport and functional activities here. We want to progress the exercises from phase 2. We can start some eccentric elbow flexion. We can also start some resistive diagonal patterns as well. And again, just make sure they're not too sore before progressing them to new exercises. So here's our next breakout. We're going to do some diagonal patterns here. First will be D1 extension. You want to make sure that the patient, you can use it manually or you can do it with elastic tubing as seen here. One thing I like doing is, if they can get a little tired of it because, it's a couple weeks doing this. So to challenge them, you can just simply ask them to go balance on one foot as they're doing these exercises. So you can see here the patient on the left is going to start raising his leg up and doing the exercises just like that, and it's just going to add some core stability and some core activation as well, and some full body activation while doing the exercise. Now on the right here, we made it even more challenging by adding a balance pad, not just by balancing on one foot on a hard surface. And then you see here, this is where he challenges himself a little bit, adds a balance component, and you see initially he struggles a little bit, but then he kind of gets comfortable and is able to do it a little bit better. For our next exercises, D2 flexion and extension, very similar to what we just showed in the last slide there. Same thing, working with elastic tubing here or a CLX band. As the patient progresses and kind of gets better at these exercises, you want to give them a little bit of a challenge. Simply ask them to balance on one foot, do it with a balance pad or just on hard surface. As you can see in both of these videos here, patient has a little bit of difficulty once we take one foot off the ground. So just another way to challenge a patient and kind of keep them engaged throughout the whole rehab process. And then, obviously you want to introduce a balance pad last, kind of do them. If you do the balance addition, do it just on one foot first and then introduce an unstable surface as well. You can see he's a little shaky on the balance pad, but it's really good work once you get it going pretty good. So we want to start doing some rhythmic stabilization here. One way to do that is to introduce a body blade. One way I like doing that is doing internal external rotation with a nice bolster there, and we can also do some abduction at a low angle to kind of get that supraspinatus moving a little bit. And like as you see in the other ones, I do like adding a little bit of balance component just to increase the challenge for the patient, just to keep things interesting so they don't get stagnant and bored with rehab. So to progress some of the stuff that we already did, we can start doing the I's, T's, and Y's on a Swiss ball. And as you see here, the patient will be on a Swiss ball. It kind of increases a little bit of balance component to it. And then on the right here, we can do what's called no monies, or that's at least what we call them. And that's just a little scapular retraction and a little external rotation with a band. And with most things, as you can tell, I like doing it with a little balance component. You can take one foot off the ground and make it a little more challenging. Also, for the I's, T's, and Y's, we want to add some dumbbell weight here to kind of keep increasing their strength. And as mentioned before, you want to cue them and make sure they're getting a good scapular retraction prior to doing the motion of the I's, T's, or the Y's. So after having UCL surgery, some pitchers complain about not being able to get that little bit of flick at the end of their throwing motion when they're pitching. So these exercises are going to help promote that a little bit by having them go through a very light mock throwing motion and then reaching for something and gripping it there to work on that flexion to get that snap of that wrist when they're throwing their pitches. And as you can see here, you can also introduce a balance pad to make this even more challenging. This really mimics, when they are pitching and they are landing on that one foot and really trying to flick that wrist a little bit to kind of put some movement on their ball, on their pitch, and it'll help them at least kind of get back and get ready for some functional activity. Now we're on phase 4 of rehab. This is typically the 3 to 5 month window after surgery. Our objectives here is going to start some functional activity. We want to continue to increase strength and power and endurance of the upper extremity, and we're going to make a gradual return to sports and some functional activities here. We can start some low-level plyometrics, some rhythmic stabilization. Now we want to really get on them about throwing mechanics education. We can start some light tossing, and again, we got to make sure that we're communicating with them to see how sore they are so we're not progressing them too fast, too soon, and that their body can heal and build up the proper tolerance to take on these new exercises. So to progress the eye season wise in the Swiss ball that we started in the last phase, we can make it a little bit more challenging. And to do so, we kind of do opposite arm, opposite leg action, kind of putting a little bit core stability into this as well. And as you can see, the patient in that left video is a little shaky at first, but then he kind of gets it and then he's a little bit better at it. We can also progress our quote-unquote no monies exercise on a Swiss ball, and we can add some marching legs to kind of increase core stability as well to get some whole body activation, just to keep things interesting. As I mentioned before, that's kind of going to be a big thing for such a long rehab process for these patients. So I hope everyone is enjoying these exercises as we go along, and you can kind of see how we are progressing each one and making it a little bit more challenging as we go along and we get better. Some other exercise to do here, it could be some body blade activity overhead to kind of get them in this nice strong position and have that rhythmic stabilization in that position where they're a little bit vulnerable after having surgery. We can also start working on some core here as well, which we could have done throughout, but now that they're getting close to pitching again, they're going to really need those obliques to work really well. So you can just do some cable wood chops here as seen in this video here. So it's just another idea to kind of get them going later in these phases to get them ready to start throwing again. So during this phase, like I said, we really want to educate them on proper throwing mechanics. To do that, we can have them start doing some ghost throwing is what I call it. It's all about form. We want to make sure they're going through the proper motion, proper good wind up, and have all the right keys here and are moving nice and slow and can kind of tolerate that. You want to start off slow and obviously increase and make it go a little faster. Another fun exercise I like doing here is manual internal external rotation. As you can see, they have the patient side lying on the table. You want to resist them going into internal and external rotation, and then after you kind of get the muscle a little bit fatigued, then you want to push a stabilization, do some perturbations, and just to keep working that stabilization of that shoulder. This can kind of really get them tired, and it's always good to break it up to do some manuals on top of the cable exercises and things like that. please make sure you grab a partner and you guys do try these. These are kind of good burnout exercises, so just give it a go. And then sorry for that little technical difficulty we had at the beginning there. I'll replay this ghost throwing video. So just, you just want to get them to work on their throwing motion, make sure that everything's working in sync with each other, and there's no poor mechanics that you kind of witness. If there is, you kind of catch it early and can kind of fix it ahead of time. So like we said, we can start some lower level plyometrics here. We want to start with a simple elbow flick. You want to have them supported and have them flick their elbow and toss the ball into a trampoline or a rebounder to kind of get them going that way. And you really want to focus on form, and with all things you want to make sure they're not too sore to do this. We can also do some shoulder internal external rotation tossing just to kind of work on form and just get them going in that position. And with most things that you've seen so far, adding a balance component is always a little bit more challenging. In both of these videos, as you can always increase the balance challenge by adding a balance pad instead of just having them doing on a flat ground. As we get close to the end of this phase, we want to start getting them into, actual throwing motion. So we want to start them slow by, getting their trunk twisting and throwing as well. We want to make sure that their shoulder stays up, we're not putting too much stress on their elbow, and they can tolerate this exercise. Then to progress that, we add a step to it. We add a step and toss into the rebounder, and this just helps, prep them to do some long tossing because they're going to start the throwing program very shortly. So for the fifth phase, typically that 5 to 9 months post-surgery time, we want to really make sure that they have kept all their range of motion, have maintained their strength, got full scapular stability, and are really good with everything. Now we can start beginning the throwing program or sport-specific activity. And again, focus on soreness. We want to make sure that they don't have too much DOMS in between exercise and rehab days, so we're not pushing them too hard. So now that they're, almost on their way out and almost ready to get back on the mound here, we want to start doing some full body exercise to get everything going all at the same time. So first thing, we could do a full body monster walk, which is some lateral stepping with some shoulder retraction and doing like a W. And then we can also do some wall squats with a CLX band with a shoulder raise, just to kind of make it interesting. Do some full body motions because they're going to be ready to go back on the mound, which is a full body motion for sure. So we got to make sure that they're training the whole body all at once as well. So some things we can start doing now is, focus on the full body and kind of get them ready to get moving. One is, do a little glute activation and arm swing to help with their running form. Just, because they've been a little bit inactive for a little while and they should have been running, but just to make sure, just to correct any biomechanical issues that you may found, just to kind of get a whole body system going. Another thing I really like doing here is that when they're really progressed, to start their I's, T's, and Y's on a TRX suspension system, which makes it a lot harder, and they're pulling their body weight now. And all you got to do is just change how far they're standing and the angle at which they're pulling themselves up to kind of change the amount of body weight here. You can even do some rows with this as well. You can do them unclose to the body. You can do a kind of like a little bicep curl with that as well. And then you can even do a wide elbow row as well, just to kind of get those scapular muscles moving as well. So just another thing to progress it and just to keep making it challenging as they get stronger. They should be able to tolerate this as they're kind of get to this point. So just another thing on the TRX too is that if I can get this video to replay for us, if he were to move his feet closer to the wall here, it would increase the amount of body weight he'd have to pull up into that T and Y. So you can obviously start them at a decent angle like he is standing here, and then as you progress it, you can kind of get them lower and lower and get their feet close to the wall and increasing the body weight that they have to move while doing these exercises. Now that we worked worked them really hard, and they're ready to start throwing. We got to make sure there's no pain and swelling after any of these throwing sessions. We got to make sure they have the ability to maintain proper throwing form, and they have to complete each phase to move on to the next one. They can't do 3/4 of it and like, oh, we're pretty close, let's go to the next one. No, we got to complete the full thing, and we got to make sure they don't have any adverse reactions to starting to throw again. So as you can see here, we're going to start at 45 feet. We're going to do some warm-up throws. Then we're going to take a 5-10 minute rest and do some more warm-up throws at 45 feet. And then we're going to, step 2, some, 25 throws at 45 feet, rest 5 to 10 minutes. Another 25 throws, rest 5 to 10 minutes. Another 45 throws. So we're going to slowly progress them from 45 to 60 feet to 90 feet, 120 feet, 150 feet, 180 feet. We're going to do flat ground throwing, and we want to make sure that they're ready for it, just nice and slow, and it's going to be performed every other day. Unless the physician or physical therapist, athletic trainer want to push it a little bit, but you want to perform each of these steps a couple times to kind of get them used to it. And again, you got to make sure that they're not getting extremely sore or they have any pain, swelling after throwing, and that they maintain proper mechanics and good form throughout all this. They should have the muscular endurance and scapular stabilization to do really well at this point. So we just got to make sure we just watch them. You can even record them at this point and show them afterwards to kind of show them what they're doing. Especially, if they say they get to step 2 and they're, on their third set of 25 throws, about after 10 they start lacking form. So you can just kind of show them like, hey, look, this is kind of where you start dropping your elbow, or you start going back to something that you used to do before. You just want to pay attention as they go through this phase and increase their distance. Then as you can see here that this is going to be about a 14-step process, so you want to really educate them and get them into a good habit of practicing a new warm-up. They're going to be regular visitors to the athletic training room or physical therapy clinics, and to get their warm-ups in prior to throwing. They're going to be pretty meticulous at this point, so many months out away from surgery, that they're going to really buy in and develop new habits. I've had somebody in the past, he had a very strict routine that he would do every day prior to pitching again after he had the surgery and he was back on the mound. So this is a good time to implement something, a really good warm-up that they can use every day when they do their throwing, just to make sure they're ready to go to prevent any chance of any injury at all. So here's another quick look at, when they do start throwing off the mound. You're going to do throwing in intervals. You're not going to just let them, hey, go ahead, start throwing off the mound. You got to progress them back to doing that as well. We're going to start them throwing slow, 50% of their full capacity. And then you can use, as mentioned here in this graphic, to use the interval throwing of 120 feet as a warm-up. And then you obviously want to do this supervised. You should not have them do this on their own, especially using, making sure they have proper form when they're pitching off a mound. You can also get a speed gun if you have access to it, just to make sure they're not pushing too much, and you can tell they put a little bit extra speed on the ball. You'll be able to record them like, hey, that one was a little too fast. Go down a little bit and make sure that we're not getting too crazy here. So here's just a 15-step process to get them going back, and then we're going to start gradually putting them back into some simulated game situations, and you kind of work them through innings, have them pitch, have them sit down for a while, and go back out there. And then you want to slowly reintroduce breaking balls and make sure you're doing that at a nice reduced pace. You don't want them throwing full tilt yet. You just want to make sure that they're taking their time. This throwing progression comes from Kevin Wilkes' latest rehab of the UCL paper. So just some ideas of what's being done out there now. And then obviously, like I said, you're going to progress them gradually back into game-like situations. So if this is like a relieving pitcher, you're going to do, short inning bouts of pitching. Now, if this is a starting pitcher, you're going to have to build their endurance up a lot. And as you see, step 15, it's a simulated game. You're going to progress by 15 throws per workout. So you're going to put them on a pitch count, and you're going to slowly reintroduce going that longer distance and building up their pitching endurance. And same thing, granted, once they do it in rehab, that's great, but even when they start coming back from the injury and actually playing in real games, the coach may do the same thing, start them off as a relieving pitcher, throwing them for a couple innings, then slowly reintroduce them to starting to make sure they are ready to do that again. So return to play. At this point, we've worked with them for over 9 months or so, and they might be able to start pitching. But typically, it's definitely a next season type of thing. You're not really coming back from this in one season. You want to make sure they have full symmetrical elbow, wrist, and shoulder range of motion and strength. You can check their strength by using isokinetic testing and handheld dynamometry. So you got to make sure that they're completely strong bilaterally. They got to complete the full rehab program and a throwing program. We got to make sure that we taught them some better throwing mechanics, and they can maintain that through a full scenario, game-like scenario that we put them through. And then obviously physician and surgeon clearance to progress them and allow them to go back to playing and pitching on the mound. So with this, it's a big surgery. There could be some issues that you run into down the road of rehab. So just some possible things that could occur. An avulsion fracture of the medial epicondyle isn't uncommon. It could happen, but that's why you want to make sure you progress them slowly and make sure they're ready for each step as they go along. There is a chance that they can re-tear their UCL, which would result into revision surgery. Any of the suture sites could get infected. That's why in the beginning we got to make sure they stay clean and we redress them as needed. And they could develop some ulnar nerve pathology, but throughout the rehab process you would be able to kind of pick that up and hopefully address that effectively so they don't have any of these issues going forward. But just some things to look out for as you're going through this process with your patients. And to also help with that, you could also do some instrument-assisted soft tissue mobilization or nerve glides just to make sure that they don't develop any ulnar nerve issues. Just something else to look out for. But, nice slow process will definitely make sure that you can prevent re-injury, and, you want to educate them along the way to make sure they're not doing anything too quick too soon, and let them know that, hey, like this, we've gotten this far because we've been really diligent on what we're doing. Please don't go over and beyond, because you don't want to go take any steps back at this point. You want to keep moving forward and get back on the baseball field or whatever respective sport they do play. So following this, using the Conway-Jobe rating, overall there's about 90% excellent results coming out of Tommy John surgery. With this comparison of the modified docking and Jobe technique, the docking technique has great, excellent results coming out of it. The modified docking also has some excellent results, although it's a little newer, so it needs some more studying done on that. And the Jobe technique does have excellent results, but it's kind of a 76% compared to the 95s of the other ones. So, when dealing with this, they do have good outcomes. Just surgical technique may influence that a little bit, and obviously progressing them thoroughly through the rehab is also going to help with this as well. And going forward, a lot of people do come back from this injury. It's used to be a career ender. Now it's definitely not. It at least takes them out for a season or two. I mean, even the first person to ever get this, Tommy John himself, came back and pitched 13 seasons after that. And he has one of the highest win percentages or number of wins in Major League Baseball history. So he's up there, that it can be done and return to a high level. A lot of younger kids are getting this now, collegiate players and things like that. And even it doesn't even really hurt their chances to continue to go forward to the next level. So, like I said before, it's not career ending. It just takes a lot of work to get them back to where they were. And, barring any complications, they should be able to return to the same level of sport as they were prior to injury. And these are my resources. I'd like to thank you all for your time, and I hope you enjoyed this presentation. I hope you can utilize some of the exercises we did today, and now you get a little different feel for it now that you kind of went through them with me, and you kind of felt the burn, if you will, doing some of those exercises, and how you can progress them, and how you might not be as strong as you thought you were, but just going forward, I hope you did enjoy the presentation, and I thank you for your time.